We're going to talk a little bit about the basic screening survey that was conducted in the state, sort of a little bit of background on it. So I feel like we can't talk about the data without talking about how we got to that data. So we'll talk a little bit about the background, some methods and procedures, a little bit about the findings and data, which is what everyone's waiting for, and then some of the next steps, and that'll sort of lead into our discussion. How do we move forward based on what we found? What do we do next? Oops, sorry, I thought I advanced that. There we go. Okay. So our project funding source, the Pennsylvania Department of Health, through a grant from the Centers for Disease Control and Prevention, funded this project. So we did have some funding, kind of came from CDC to the state to kind of PCOH, and then we carried out this work. It was part of a 5-year grant that spans 2018 to 2023, and it kind of has the legalese up there. You can read that on your own. So some disclosures, I did serve as a screener for the BSS, so I'm going to share some firsthand experiences with you, but also know that I was a paid screener for the BSS. Other than that, no other financial disclosures. So how did we sort of get here? The initial plan was we were going to do this basic screening survey in the 2020 to 2021 school year. So sort of COVID had happened. We were still sort of dealing with the aftermath. Didn't work so well. So we did delay that, and then we were able to get into the schools a little bit more easily at that point. We still did have some, absences, things like that came into play, but it was a little easier working with the schools after that 2020-2021 school year. It does tie into our state oral health plan. So all of this basic screening survey, it wasn't just, hey, let's just go do this. There was a method to this madness. So it ties into the state oral health plan, which was written to promote oral health across the state. That is a 10-year plan. So that is a 2020 to 2030 year plan. And there's 3 main priorities within that 10-year plan. So access, prevention and education, and then workforce and infrastructure improvement. And within that infrastructure improvement, one of the goals is to ensure a process to sort of provide regular surveillance of specific oral health indicators. And one of those surveillance systems that was put into place was this basic screening survey. The basic screening survey is baseline data, and it will be used moving forward to determine if interventions that are being implemented as other parts of this plan move forward are having impact, and if so, to what extent. So this was the first one. It's not the last one, hopefully. So a little bit about the methods of the basic screening survey that were employed. The sites. We selected sites, and it wasn't that we went around and picked schools. There was a process to selecting sites to essentially represent the state as a whole. And there's 500 school districts in the state. There are a whole lot more schools with 3rd grade classrooms. We looked at the school level, not the district level. So if I were to look at like my home district where I went to school, there were 3 elementary schools. We didn't go into all 3. So if one of those sites was selected, it was 1 elementary school, not all of them within the district. Pittsburgh and Philly public schools did not participate. So keep that in mind as you're looking at the data here. We did not have any school district within the Philadelphia school district or within the Pittsburgh public school district that participated in this work. The data is not meant to be used at the school district level by any means, definitely not even at the district or county level. We do talk a little bit about regions in some of the data breakdown, but honestly, as this data is being interpreted and provided, it's meant to represent the state as a whole. So it becomes a little bit more challenging to break it down. I think I have one slide that does that by region, but just keep in mind it's really meant to be a sample of the state as a whole. Again, the 2021-2022 school year did still present some challenges with COVID. So some schools did choose to opt out. So we had initially 80 schools that were selected. They had to, just because they were selected, doesn't mean they agreed to participate. So they still had to be agreeable to participate in this. They could say, we're not interested, we don't want anybody coming in. And so then in that case, there were always backup schools. So if one school said no, then we would go back to that data and we'd find the next school on the list that represented students in a similar manner. So looking at how rural is that school, how urban is that school, kind of what percent poverty level is within that location. So all of those things were considered as a new replacement school was selected. Another thing was passive consent. So that's sort of how did we have consent provided to be able to go into schools and screen third grade students. So not everybody wants their third grader to be screened by some stranger dental hygienist who's coming into the district to do this survey. We did use passive consent, meaning a letter went home to every parent, and whether or not they wanted their child screened, if they did not want their child screened, they sent the letter back. So, hey, school nurse, I don't want my child screened. I experienced this in one school, and it happened to be a very small rural school where that school nurse knew, I tell you what, I think she knew every parent in the district and every kid and whose, cousin's brother or whatever it was. She knew it all. She looked at some of the consents that she got back. So some of those students who had technically opted out of the screening, and she's like, there's no way little Johnny's mom said no to this. So she gets on her phone and she calls them up. She's like, do you realize this was passive consent? So you only were supposed to send it back if you don't want little Johnny screened. And they were like, oh my gosh, no, I thought it was permission to do it. No, go ahead and do it. And so she tore that consent up. So we had instances like that. It was convenient. If it didn't come back, then we were okay to screen. But some parents might have misunderstood that concept. So how did these screenings get carried out? So a little bit about how this worked and sort of my experiences and what we went out and did. So scheduling. One of the 80 schools that was selected, they sort of divided screeners by region. And I should step back a minute and tell you that public health dental hygiene practitioners were selected to do these screenings. So you could apply to be a screener. And screeners were sort of assigned by region. So I sit in the center part of the state. I kind of covered the center part of the state. I wasn't sent to Philadelphia or to Pittsburgh to do a screening. Once those schools were selected and I sort of had my list of schools, so, okay, Kelly, you have 4 schools that you're going to do screenings at. It was my responsibility as the screener to then go ahead and contact the schools and figure out a day that worked for my schedule and for their schedule. They would usually say, what time of the day do you want to do this screening? I will tell you first thing in the morning is preferred because they have not had snack yet and they have not had lunch yet. Once they have those things, the screening gets a little bit more challenging. So we would schedule something and then we would make sure we ensured necessary supplies. So I had a list and I knew that there were approximately X number of students that I was going to be screening. I would usually just confirm that with the nurse to make sure we're on the same page. And then I would make sure that in my kit, I had enough supplies to go into that school. We would then go in and screen for indicators. I'll show you how we carried all of that stuff into the schools here in a minute. But we would sort of go in, we would screen for indicators, and it was a very quick screening. And I highlight screening. It was not an exam by any means. And it was with my eyes only. Eyes in a mirror, no explorer, nothing beyond that. So it was a basic screening, right? That's what we were getting at. We would talk, usually the nurse and I, when we were scheduling, would sort of say, like, where do you want to be? Where would you like set up? What do you need? How much space do you need? I did it differently in a couple of different districts. So one, I used a conference room. That worked well. They kind of had them all gather in the cafeteria, lined them up in the hallway, and brought them into the conference room one at a time, and we were kind of quick in and out. I used a gymnasium one time. That was kind of cute. So all of the kids sat on the lines in the gymnasium and just kind of sat there and opened their mouths. Then I went right down the line. That worked out. I used the nurse's office one day as well. So the nurse would sort of bring them in and put them in a little chair in the nurse's office, and I was able to do a quick look-see in the chair, and then they were able to go off with the rest of their class and kind of continue about their day. So it didn't take a super long time. It didn't take a ton of time out of their school day. I think that might have been some of the district's concern, like, oh gosh, we don't have time for this in our day. But it really didn't take a whole lot of time. I will tell you that I think it was the day before Halloween, but it was the day that all the kids wore the costumes to school. Bad idea. That was my first screening. I will never do that again. Was not worth it. And then we had to document the data. So I kept paper documentation and then would go home and sort of double check my chicken scratch and actually make that electronic data. And then we'd also have to communicate home with the parents. So say I saw little Johnny and I noticed that there is very obvious decay, I needed to communicate that to whoever is at home and is responsible for that child's care so that they know that little Johnny needs that follow-up care. Some of the nurses, again, some of the smaller districts were really great about, oh wait, who needs all of this follow-up? We're gonna jot a note down and we're gonna call and follow up with that patient's parents as well. I had one school nurse that was like, oh my gosh, so glad you're here. So-and-so's mom called this morning and he was jumping on the bed and he chipped a tooth and I want you to look at it. I told her the hygienist was coming today and it would be great. So we had an instance of that as well. I'm like, that's not really why I'm here, but we do want to make sure he gets to the dentist. So we had some instances like that as well. Overall, they were really grateful to have somebody looking at children's teeth in the school. A lot of the school nurses were very grateful we were there, had a lot of stories to share and like, what do I do if I see this or how do I handle that? So they really sort of liked to have that ear to listen and to be able to sort of point them in the right direction as well, which again, wasn't really the point of this, but unintended consequence that was actually, I think, a positive in helping them to even learn a little bit more about some of the resources in their area. So how did we actually do this? I think this one might have been Helen's car, but all of our cars pretty much looked like this, and I think we had to sort of have a way to be able to transport this. So you had to make sure nobody was driving like a smart car on the way to do these screenings, because we traveled with a lot of things. So we had big bins, and they had wheels on them, and you could pop in the back of the car, and you could wheel them into the school. All of our supplies were kept in the bins, and you might have had, like, again, I did 4 schools. I didn't have to take all of those supplies to every school. I could sort of count it out and make sure I had just what I needed in the bin, a little bit of cushion for extra, and be able to kind of cart that out. So we had disposable mirrors in those bins. We had gauze. We had sort of the PPE, so gloves and masks and Sani wipes in case we needed to kind of clean up afterwards. Trying to think what else we had in there. So the mirrors, the gauze was really all we used for the screening. We were not using explorers or anything of that nature. We did have toothbrushes to hand out afterwards. I think we had floss picks as well. And that's about it, right? And then I had my data sheets, so sort of where I was going to record the data that I was seeing or what I was seeing as I was screening that day. All of the PhDHP trainers were calibrated prior to going out and doing screenings. So we needed to make sure that it wasn't just Kelly going out as a PhDHP and in Kelly's opinion, that looks like cavities or caries. And so I'm going to mark it as caries. Everybody had to be on the same page because my definition of that looks like a cavity might not be the next person's definition of that looks like a cavity. So we did have calibration 2 sessions ahead of time, and it had to be obvious decay. So again, you weren't getting an explorer in there and saying, oh, well, that feels a little tacky. It needed to be obviously cavitated for me to mark it as this child has a cavity. We were also looking for sealants on third molars. So, 6-year molars. So third grade students typically have their first molars or their first permanent molar. And so we were looking for a sealant on those teeth and what percentage of children has sealants by that point, by third grade. So sort of why did we choose third grade? They could have had some caries experience by that point, and they should all have their first molars in enough to be able to be sealed. And there should have been some time in there for that to happen, because those molars typically erupt around age 6. So in theory, if they were going to have sealants, they would have had them by then. So we were looking for sealants. We were looking for obvious decay. We were also looking for a history of cavity experience. So did they have a filling that indicated previously that they had a cavity? Or was there a tooth missing that should have been there that probably was lost because it was so far gone due to decay? So we were looking for those kinds of things. We also rated how urgent does this child need to get to the dentist? Do they have an urgent need right now? Do they not? Is it a routine referral? Is it they have an abscess, and we did see that unfortunately, where this child has an abscess and they need to go like today, tomorrow. So we sort of ranked their emergency on a scale, and that got sent home with the parent as well. And again, in my experience, the nurses, especially when there was an emergent referral, they wanted to know sort of which child that was so that they could follow up and make sure that that child continued to receive some care. So as far as the data, the part you've all been waiting for, right? There were 6,000, just over 6,000 students that were invited. Of those 80 schools, about 6,000 students to be screened. Just over 4,000, so about 4,200 were screened. So why was somebody not screened? It could be that the guardian or parent opted out of the screening. It could be that little Johnny was sick on the day of the screening, so they didn't come to school. So those are some of the reasons why we might not have seen all 6,000 children. But we got 4,200 out of the 6,000. Again, 500 school districts in Pennsylvania. There are almost 1,600 schools in Pennsylvania that have third grade students. So again, when we talk about district level, 500 school districts, and then when we talk about how many elementary, or sometimes it's like an intermediate school that has a third grade classroom or a couple of third grade classrooms, just about 1,600 schools. And then of those 1,600 schools, 80 were selected for the screening. There were 74 schools screened. Private schools were not included, but charter schools were included. And homeschooled students were not able to be counted as part of the screening. So some oral health indicators by geography. So we look at caries experience, we look at untreated decay, treated decay, so did they have a filling that indicated their decay was treated. The treatment urgency, so was there no treatment urgency, kind of early or urgent treatment urgency, and then did they have sealants on primary molars. And again, remember, we don't want to look necessarily by region, we'd rather look whole state. So we divided this up rural and urban. And you can see that, so rural's on the top in the darker color, urban's on the bottom in that lighter purple color. And you can see caries experience is pretty equal across the state. Again, untreated decay, pretty equal as well. Where we get into some bigger discrepancies are where the circles are. So treated decay, urban tended to have a higher rate of treated decay. So those children were getting their needs maybe met a little bit more, right? Their treatment was being rendered. More so than urban. And then in terms of sealants, rural did better, like almost by a landslide, really, when we look at those numbers. There's a pretty big discrepancy there. So pros and cons to rural and urban. So if we break it down by race and ethnicity, again, looking at the whole state, and we look at some of those same factors. So first looking at caries experience, and I'm actually going to say caries experience along with untreated decay, because when we look at the Asian population, they have the greatest disparities. So those children of Asian descent have the highest rate of caries experience, and they also have the highest rate of untreated decay. You may also be asking, well, how did you know race, ethnicity? How did that all get recorded? There's numbers that we weren't necessarily privy to, but like a student ID number lines up with a number that the state has, and that state has kind of all that data linked to that child. And so there was some back end work. I didn't necessarily know that this child in my chair now has all of these like race or geographic indicators, or that they're on free and reduced lunches, but the state knew that, and they were able to kind of take those two numbers. So I worked by student ID at the school level. The state was able to kind of match up school level ID with kind of full ID at the state level and have all of this demographic information on those children. We also, if we look at Black or African American children, their rate of treated decay is the highest, but they also have the highest rate of urgent treatment needed, and I found that interesting. So we're saying, yes, they have a high rate of treatment, but there's still a lot of work to be done in that population. And then again, I told you we can't really look at this by region, but we did. So you might be wondering sort of, well, how did my region stack up? Again, this is meant to be statewide data, but I think it's interesting to sort of see what area of the state has the highest rate of cavities or caries. And that's the southeast region. And again, the northeast region. I think the wrong one was highlighted. Yes. Sorry. Been through this how many times, and I'm like looking at this saying that doesn't make sense. The northeast region had the highest rate of caries instance as we went through. So, and again, remember though, that southwest and that southeast, we didn't have Pittsburgh or Philadelphia public schools. So could that have changed the outcome? Maybe, which is why we're not looking by state but by region, or by region but by state. Go ahead.
Yeah, can you go back on the last slide? So when you looked at race, were they roughly about the same percentage as far as students? Or?
So it was what does the state as a whole have? So out of the state, how many students are white students? How many students are Asian students? So we're trying to represent the state as a whole. So whatever that percentage is of how many, white students or Asian students are in Pennsylvania as a whole, we tried to get that same percentage of students being screened. So that was sort of part of that, how do we choose the 80 schools? We're trying to kind of represent the state as a whole and using those ratios to help us out. Absolutely. So again, breaking it out by region, you can find your region, sort of see how you did, but keep in mind there are some potential discrepancies there. And then we need to look at the way forward. So sort of how can we impact the oral health of third graders, knowing what we know based on this screening. We know where we stand now or where we stood last year. How do we impact that and make it better moving forward? So how can we, some of the ways that we can do that, some state-based dental sealant programs, right? So if we can increase the rate of sealants, potentially we decrease the rate of decay. Community water fluoridation is one potential method. Increasing Medicaid enrollment, so provider enrollment in Medicaid, and then also increasing reimbursement, making it potentially more valuable for folks to see patients that have Medicaid insurance. Integrated access to care, so kind of medical and dental. Also targeted outreach, targeted education. So if we know one area has sort of a higher rate of caries, how can we target that area to make a difference there? Some cultural competency training to try to kind of even out some of those cultural differences, and then increasing access to affordable care is something that we can work on as well. So with that, we'll go into our 20 minutes. My email address is there in case there's anything after the presentation that you'd like, or I'll be around today, tomorrow as well. And I also did link the BSS online report as well. So if you're like, oh, I want to know more about how my region did or how things were across the state, some of the disparities, the full BSS report is there. And like Helen said, you'll have the slides so you can click out and read that after the event. So thank you, everybody.